Good morning, good afternoon, and good evening, everyone. Greetings from Wockhardt. I am Dr. Shahu Ingole, Head of Medical Affairs for Wockhardt Pharmaceuticals. I welcome all the delegates who have joined us from the various parts of the world for today's live international webinar on transforming Indian healthcare via telemedicine. Dear delegates, we all know that providing in-person healthcare is becoming more and more challenging nowadays just because of the geographical distances and the limited resources. And in addition to this, the disasters and the pandemics like COVID-19, they pose unique challenges with providing the healthcare. And we know that the information and communication technologies, they have the great potential to overcome some of these challenges faced by the developed and developing countries in providing the accessible, the cost effective and high quality healthcare to the patients. Telemedicine uses this information and communication technology to overcome these barriers and has become the need of hour. And therefore, to discuss this in more detail, we are honored to have with us the esteemed panelists who are the experts in the field of telemedicine, Dr. Jaideep from India, Dr. Sachin Kedar from US, and Dr. Saurabh Jain from UK. So welcome all the three speakers for the today's live international webinar. Now, without wasting much time, I will move on to the first talk of the today's webinar by inviting Dr. Jaideep. Dr. Jaideep has completed his MD Physiology in 2003. He is the Associate Professor for Physiology, Pondicherry Institute of Medical Sciences, Pondicherry. As an inspiring cognitive neurophysiologist and an education technology thought leader, he brings in more than 20 years of experience in the health industry. He has been phenomenal in developing and implementing the technology-based education system and healthcare. He believes that the only way to know the future is to build it, and that begins by challenging the status quo. With this, I welcome Dr. Jaideep and hand over the session to him to take his session. Over to you, sir.
Thank you, Dr. Shahu. Thank you for the wonderful introduction. And let me just start my screen share, and then we'll move on.
So before we start with the first talk by Dr. Jaideep, I request all the delegates, if you have any question, just please type your question in the chat box, and we will take these questions one by one at the end of the third talk during the panel discussion.
Right. So I hope all of you are able to see my screen.
Yes.
Yes. Right. Thank you so much. Right. So just to begin my talk, as Dr. Shahu rightly mentioned, this is all we are doing a very different thing. It's about telemedicine, and the reason I just wanted to put this slide up again is that in the past 20 odd years of my experience, I've had the opportunity to work with some industry leaders, and most of these institutions and organizations are actually right now practicing telemedicine to some extent or the other. But let's begin with a story, right? We all like stories, and this is the most famous painting by called "The Doctor" by Luke Films, and I'm sure all of you at some point have seen this. It inspires budding doctors in all medical colleges, and here we see a doctor, and who's just next to the patient, and just looking at the child and wondering what to do with it, and in all this, after all about 120 odd years now, we are here. How did we get here? The doctor is sitting in one different place, and the only thing that the doctor has in front are multiple screens. But there's a lot of information which is going on, and so many technologies are there coming together. Everything is there except that the patient is not there. So once again, I just want to greet you and say good morning to some and good evening to some. But I'm just here to give you a very brief introduction on the fundamentals of telemedicine. And by telemedicine, we want to ask the first question, that is, what is telemedicine? So, telemedicine, as defined, is the delivery of healthcare, and where distance is a critical factor, by all healthcare workers using information and communication technologies for the exchange of valid information for diagnosis, for treatment and prevention of diseases and injuries, for research and evaluation, and for continuing education of healthcare providers, all in the interest of advancing the health of individuals and their communities. And this definition comes from the World Health Organization, and this definition has been picked up by the Medical Council of India also. And as we read through this definition, I see that we have a pre-webinar poll. So, which Dr. Shahu, so shall we let the participants go ahead with the poll? It's on the
Yeah, so
screen.
during the talk, I request all the delegates to answer these two questions for the pre-webinar. And Dr. Jaideep, you can continue with your talk.
Sure. So telemedicine is this. There's a broad definition of telemedicine, and wherever there is the need for healthcare professionals providing care. At the same time, there is another concept called telehealth, which also the NCI clearly defines, and this is the delivery and facilitation of healthcare and services. And apart from that, it also includes concepts of self-care using technology and digital communication technology. So digital health, right? So this is what's been happening. And in India, there is the e-health India initiative. This is already in place, put by the government of India. And there is a school of telemedicine, which is well established in SGPGI Lucknow. And along with that, if you open the e-health India portal, you will also find that there is a telemedicine OPD called e-Sanjeevani, and all these activities of telemedicine are coming under the Telemedicine Society of India. Now, India, the initiative was taken initially by the Apollo group of hospitals when they connected their rural hospitals with their main hospitals in Chennai, taking the help of the Indian Space Research Organization. So, India has been doing a lot of work in the field of telemedicine till now. But in all this, some people might ask why telemedicine is not yet so popular. And for that, we've had a very big step which has been taken just 5 days ago, in fact, by the Medical Council of India when they released in the Gazette of India the regulations concerning the functioning of telemedicine in India. And I'll just quote a few main headlights from that notification, and they begin by classifying telemedicine into some four broad categories. We'll briefly look at them, and they have classified into the how you can say telemedicine is by different modes of communication, by the timing of the interactions, by the purpose of the consultation, and the different interactions which take place between the different individuals involved in the communication, right? So these are the things. I will go one by one into different. So the if by take the mode, you can always classify the telemedicine as using video and video, or by using audio, or by text. So text could mean your SMS or WhatsApp text, or just simple fax also is being considered as a text, and audio is just where you speak and there is no face-to-face interaction is what will come in the video. Now, if you take about timing, you can have a real-time interaction like what we are having, right now, face to face. Most of us can see each other, or we can have an asynchronous where you send a message, like you send an email to your doctor. That will be an asynchronous kind of a interaction. Then there are different purposes. You can have an emergency consultation or a non-emergency consultation. Emergency consultations will need to be done only in extreme emergencies. But even there, you could help somebody because if they are not able to reach a hospital. But otherwise, in emergencies, it is always best to physically go to a physician or to a hospital. Non-emergency consultations, they've again split up as a first consult, where you see a patient for the first time, or you are seeing a patient for the first time after a gap of 6 months. They are to be treated as a first consult, but all other consults, if you're seeing them again, they will come under the follow-up consult. And as you do the follow-up of your chronically ill patients or your post-surgical patients, you will be able to do that. Next classification would be the type of interactions you do with the different individuals. So you can have interaction between a patient and a registered medical practitioner, a doctor. You can have an interaction between the caregiver of the patient and the doctor, or you can have interactions between the two doctors, between the registered medical practitioners or health workers, Anganwadi, ANMs, nurses. They can contact on behalf of a community or on behalf of an individual to a doctor, and these are also the parts. So different ways they have very beautifully. The document has come out where we can see that the people are. It is very clear. There are no doubts once you read the document. So, but I want to ask what to do. How do we go ahead? What do I do now? So, I'd like to put our interactions with the doctor as a patient will always fall into three different phases. So in all these three phases, we can use telemedicine. Telemedicine can be used beautifully in promoting health. Patients can register with doctors and get good advice and consultation as to how they can lead healthy lives. Or if they feel they are susceptible to certain diseases, they can be advised on how to prevent those diseases, what are the preventive methods that they have to take, what are the drugs or what exercises or what diet can be taken. All that can also be communicated to the patient by using telemedicine. Finally, if a person does have a disease, we need to give a prescription. We go ahead with the telemedicine consultation, and we can use after the disease has subsided as a follow-up, or we can go ahead and even for rehabilitation, we can use telemedicine. But the question you might ask again is, okay, now where do I stand? Where do I start? And it all depends again on you and your patient as to what is the level of engagement you have. So I would like to put them into, like, there are 5 different stages or phases where you can start from the very basic, just a voice based or an internet based interaction. You can have algorithms to assist you, and you can have variables to assist you, or you can have the full stack. We'll just see all these in detail. So Alexander Graham Bell, as soon as he invented the telephone and people were speaking to each other, I'm sure people were calling up doctors and asking for help, asking for advice, and all that is probably the extreme beginnings of telemedicine. But Alexander Graham Bell also had a dream that not only will we be able to hear each other, but we'll be able to even see each other. So, in spite of the various progressions that we have made in terms of telephony and audio, there is only some information that can go across a telephone. And for that, when the internet came, we are flooded with so many different tools in which we are actually able to see each other. The video call, like whether it's WhatsApp, Facebook Messenger, Skype, or Zoom that we are using, or Google Meet, or many others, or even many hospitals have their own video chat systems where the patient and the doctor are able to see face to face and talk, and that is also very good because identity is a very important thing. You're able to identify the patient, you're able to identify the doctor, that's the real person talking, and a lot of clinical information can come out just by using a simple video thing. But it's always, if we take it to the next level, we find that there are algorithms, clinical decision, supporting systems where you can use a lot of computer-based systems where by putting your data into the system. For example, there's this beautiful app called ADA from the US where you just feed in your data. It'll ask you a lot of questions. It's like a chatbot, but you reach a very close to a good diagnosis. And of course, the MCI regulations state that we cannot solely depend on artificial intelligence-based systems uh, to make a diagnosis or even to give a treatment. But yes, it will be very good if we get assisted by that. We can use it prior to the consultation or even during the consultation it can be used. But all algorithms to run, we need lot of data, and this data we can get like I picked this from the internet. We can get by using wearables. We can use FDA approved wearables which can be worn all the time, like all your Apple Watch or the speedometers. You can use different apps which come with these wearables, and this data, when it is transferred from the instruments through the telecommunicating device and through an electronic medical records or electronic health records, then we can take it up to the expert medical opinion, which is what comes to the next thing, is to actually enable your patients to have wearables on them or with them. So, for example, lot of lives have been saved, especially in the US, when people have used the Apple Watch or even the cardiac ECG machine to detect atrial fibrillation. And doctors have been informed much earlier than actually patient getting some kind of a cardiac disaster. They have been able to reach out. Doctors have been able to know that something is wrong. So we have a wide range of wearables available these days, which you can prescribe to your patients. To check their temperature, to check the fertility, and to check heart rate, heartbeat, and now a lot of I'm getting emails from local people who are making COVID specific wearables where it will sense heart rate and temperature at the same time also. And when we have all these information, we have the wearables, we have the electronic medical records maintained both by the patient as well as the doctor, we can have a better medical opinion, and then we can present a holistic picture. And that brings us back to our beginning slide, where we see that there is a doctor, the doctor has access to the patient face to face, the doctor has access to his colleagues, he's able to access their old radiology and their x-rays, their current the vitals and pathology reports and everything. You can actually send a vehicle to the patient's home to collect some of this information. The doctor really need not go there, or maybe there could be centers, peripheral centers, or setups can be put up at people's home itself, where this data can be collected, and this data can be then collated and put together for the medical professional to take a decision. And all this, yes, it is happening in small ways, and there are companies which are available which are helping out doctors to from hardware and software solutions and back end tech support, people are able to provide these solutions to us. So thank you very much. I hope I could give a brief introduction about the fundamentals of telemedicine. You can link You can contact me on LinkedIn, or if you scan the QR code, you will be able to get my other contact details. So thank you, Dr. Shahu. I'll hand over to Dr. Shahu.
Thank you so much, sir, for such informative and elaborative talk regarding the basics of the telemedicine. So I move on to the next topic, which is very important and must know for the clinicians on how to set up the telemedicine practice, because this will be the question that everybody will be asking today. So to talk on this, I invite Dr. Sachin Kedar, sir.
Dr. Shahu, there is a relaunching of the poll. More than 300 delegates are there. So I would request them to kindly cast their poll.
Yeah, so before Dr. Sachin start his talk, I request all the delegates to put their answers to the poll. So I welcome Dr. Sachin Kedar for his talk. Dr. Sachin is done MD Ophthalmology from AIMS Institute. He's a neuro-ophthalmology training Embroidery University. He's a division chief neuro-ophthalmology and ocular electrophysiology VNMC. He's the program director, neurology residency, fellow, American Academy of Neurology. And his academic goals are to develop the novel learning tools, research ophthalmic biomarkers of neurological diseases. He is currently the professor of neurological sciences, ophthalmology and visual sciences, University of Nebraska Medical Center. So with this, I welcome Dr. Sachin sir and hand over the session to him.
Thank you, Dr. Shahu. Let me get my screen up. Well, good evening, everybody, and good morning for those of you who are in the Western world like me, where it's bright and early in the morning. So my goal today is to talk about how can you practically set up telemedicine program in each of your individual clinical practices. The fact that all of you have registered and are attending this Zoom webinar today tells me that you have already accomplished the first few goals. So before we start, I hope that all of you are aware of the gazette that was recently released on May 14, 2020 by the Government of India that Dr. Jaideep just went over on his talk. This guideline provides important rules and regulations, as well as some guidelines about how you can establish your clinical practice in an Indian setting. So by the end of this talk, I hope I have helped you to design a telemedicine clinical setup that is customized to your work needs, that uses resources that are available to you, that meets your patient's needs and expectations. It is consistent with safe and ethical medical practice, is compliant with all existing regulations, and most importantly, it gives you the joy of practicing medicine like you are traditionally doing. So I come from an institution, the University of Nebraska, which is a pioneer in telemedicine, having instituted this as far back as 1955 to provide mental health care to rural Nebraska. So I come from a rural state where this is important. And over the decades, this telemedicine program has grown to both inpatient and outpatient settings, helping save lots of lives and reducing the costs of healthcare, which are so important today. So when I talk about telemedicine in your practice, I go through about 6 steps, which I urge each one of you to do before you decide to jump into it. The very first step is to understand why you want to do it. What are your goals for telemedicine practice? Now, because of the COVID pandemic, things seem pretty obvious to us. Yes, we want to reduce the risk of COVID-19 exposure for our patients and staff. We want to provide treatment to all our patients who may otherwise not be able to travel to clinic because of travel restrictions or lockdowns and so on. It will reduce the cost and inconvenience of travel to clinic. You want to make sure that your valuable clinic resources are preserved. Now, what are these resources? Your staff, yourself, your practice, your jobs, your revenues, all of those need to be preserved. And as a training medical director, for me, this is important because it plays such a vital role in medical education, such as we are doing here today. Step number 2, understand your practice. Now, this may seem pretty obvious to you, but when I started, it was not so obvious. Where do you practice? What do you practice? How do you practice? What percentage of your practice is new versus established patients? What percentage of each visit from a patient is spent in verbal communication versus physical components? What percentage of your patients need critical hands-on component or procedures that you cannot do by telemedicine? Do you have to do all of those procedures, or do you have an assistant that can do all of these for you? So when I answered these questions for my practice before I started telemedicine, these are the answers. I practice in an urban setting. I practice specialist care, which is neuro-ophthalmology. 30% of my practice was inpatient in hospital, 70% was outpatient, slightly less than half were new, and others were established patients. In each patient encounter as a neurologist and neuro-ophthalmologist, 75% of my time was spent in verbal component, getting a history, counseling the patient. And of all patients who came to my clinic, at least 50, if not more, needed some form of a critical hands-on component or procedure like getting a visual field or doing a fundus examination. But I also realized that in 90% of these cases, I could have somebody else do those procedures for me. I could get a fundus picture, I could get a visual field, and these were necessarily not something that I had to do. Step number 3, once you've decided and looked at your practice that you want to do telemedicine, answer these questions about the logistics of it. Do you and your patient have visual, verbal, and textual modes of communication that Dr. Jaideep had referred to? Are these modes permitted by existing regulations? And we now know that from the latest MCI guidelines, they allow you all of these 3 modes of communication. Are these consultations billable, and will insurance cover these costs? How do you need to document? What do you need to document? When I answered this, for me, it was yes to the first question. And at least 60% of my patients, even those in rural Nebraska, had at least one of these modes of communication. These were permitted by existing rules and regulations in the US, similar to India. In the US, they were also billable, and insurance would cover those bills. And the type of documentation that was needed were governed by a regulatory body called the CMS. And these are very similar to what we did in clinical practice. And again, most of these mirror the guidelines that were recently released by the government of India. Step number 4, how do you do it? What is your setup? Now, as you can imagine, telemedicine, you don't have to be physically at a given location. You can set up your office either in your clinic or at home. Here is an example of a setup which is actually at home. You should have at least one method of visual communication and one method of verbal communication ready. So you are on the internet today. If you have a phone video, that is 2 methods. Consider having a staff whom you have trained, who knows what to do, who can help you with the visits. Whenever you're on a televisit, make sure you maintain a professional, personal, and workspace appearance. Make sure that you have mirrored the clinic in your telemedicine setup. It is very important for your patient to see that you're taking this very seriously. So now you've set it up and you're ready for your first patient. What should you do? Before you start the televisit, make sure you get a consent from the patient or caregiver. Now, Government of India says that if a patient calls for a televisit, the consent is implied. What I would urge you to do is get a consent nonetheless. Clearly inform the patient that the televisit may result in the need for additional information, may need a brief visit to the clinic for a examination. Maybe there are components of the examination that you need to do in person. Also tell the patient that the visit will be billed. You do not want to give them a shock later. Make sure that your assistant can check in the patient through the agreed upon platform, confirm their identity, and make sure that they have consented. So for example, we are on Zoom today. Your assistant can check in the patient on Zoom and then allow you to join the Zoom and do your part of the examination while the assistant can wait for your instructions. The actual televisit, now that your patient is on Zoom and is waiting for you, you have to maintain the same professionalism that you would during an actual visit. Now, I am presenting a talk here today, and I am presenting it exactly the same way that I would do in an auditorium filled with 300 odd people. Get a history, get a full history. You can do all of it by either video or telephone visit. There is no component of the history that you cannot get. Examination. Believe me, a significant part of your examination can actually be done on the video visits. Involve the patient's family in the examination. Get documents from other RMPs and corroborate their findings. The key is innovation. You have to innovate to be able to stay through the examination. Now, this is what I do. I'm a neurologist and then I'm an ophthalmologist, and I can do pretty much 75 to 80% of these examinations simply by televisit. So on a neurological examination, I can easily assess cognition, language, speech, cranial nerves, motor examination, coordination, and gait simply by observing or having the family perform those procedures for you. And the family is very, very eager and interested to do those. I can do practically 3/4 of the eye examination simply by observing and having the patient read something, read out colors. The family member does confrontation visual fields. I can do a full eye movement examination. I can do a torchlight examination of the eye, and I can do a pupil exam. The one thing that I cannot do currently is a fundoscopic examination, and that is the component for which the patients may have to come to the clinic or to somebody else to get a fundus photograph. Step number 7 is decision making. Do you have enough information by which you can make a decision about the patient? Now, if you've decided that the patient has urgent or emergent needs, it is your responsibility to provide first aid and send them to the closest emergency department or casualty. In all others, you have to first ask yourself the question, does this patient really need to come to my clinic to complete some part of the examination? Can I counsel the patient? In most of the cases, you can counsel the patients. You can order tests, blood tests, or you can order radiology tests. You can prescribe treatment. But before you prescribe treatment, make sure you go over the list that was recently prescribed in the Government of India regulations that Dr. Jaideep was referring to you. Document the visit. Document it exactly the way you would document somebody coming into your clinic. Make sure you note the start and the end time, which is a log of the visit. Make sure to tell your staff that you have these follow-up requirements for the patient and they need to take care of it. Models. So there are different models and these are all intuitive. The easiest one is tele-video visit, which is a Zoom or any other face-to-face platform that you can use. You can do a telephone visit where you cannot see the patient. It is suboptimal, but you can hear the patient. You can do hybrid visits, which is what my practice is now engaging in, where you do a bulk of your visit on the video, and then you will instruct the patient that I need to do these 2 or 3 components in clinic. Can you come back? And the reason for this is you want to reduce the foot traffic in your clinic. You want to reduce the chance of exposure to COVID, and you want to make sure that your patient and yourself and your staff is safe. We have recently embarked on something called a mobile van visit. Some of you are already doing it in India. It is a van which is equipped with all the necessary tools that you have, such as a camera or something else like that. It goes across town, or patients can come into the parking lot and get tested. Again, the goal is simple. The less traffic in your clinic, the more healthy your staff and the patients are going to be. Some useful tips as my last slide. This is a new concept, and if you have not done telemedicine previously, I would suggest starting slow. Have few patients, have patients with reliable internets, have patients who are in follow-up visits with you. because there are going to be kinks that you have to work out. The first few visits, give yourself twice as much time. Make sure you have trained an assistant or a staff to help you. Make sure and consent the patient, because that is where you're going to get into trouble. If your expectations do not meet those of the patient, there will be trouble. Document the visit exactly like you would document any other clinic visit. Make sure that whatever you have told the patient about your plans are clearly documented, established, and followed through. Do not let the patient fall through the crack. So that was my experience in setting up a telemedicine clinic and practicing telemedicine clinic. And I hope that these will be something that will be useful to you as well. Thank you. And I hand over the presentation back to Dr. Shahu.
Yeah, thank you so much, sir, for giving the step-by-step approach for setting up the telemedicine practice. And I think you have captured every minute details of setting up the telemedicine practice. So thank you so much. So delegates, when it comes to practicing the telemedicine, and when it comes to using the telemedicine in day-to-day clinical practice, I'm sure that there are a number of challenges you may come across. So to talk about these barriers and how to overcome these challenges, I invite Dr. Saurabh Jain. Dr. Saurabh Jain, he has graduated from MMC 1997 and GNEC from 2001. He is the consultant ophthalmic surgeon and clinical director at Royal Free Hospital, London since 2009. He is the honorary associate professor, University College of London. He is the training program director and SEAM lead Health Education England. Dr. Saurabh has expertise in pediatric ophthalmology, strabismus, and cataract. So with this, I welcome Dr. Saurabh Jain and I hand over the session to him.
Thank you very much, Dr. Shahu, and to my other colleagues. So I will just attempt to set up my. Okay, so I hope you can all see my screen. So I have to say, the previous two speakers have done most of my work for me, and I'm just going to talk a little bit about the barriers I faced when we had to adopt telemedicine here in London, and how we sort of overcome at least some of these challenges. We talked about the different modes of telemedicine already. We can have quite basic telemedicine, which is text-based, which could be asynchronous, which means the patient texts you and then you text back at some stage. It can be audio-based and can be video-based. The more the technology that you use, the more the barriers you probably overcome. And I'll talk about that a little bit. So now, if you're going to use text, one of the problems is the interaction is very limited. So it is difficult to identify the patient, it's difficult to identify the doctor, and you have to spend maybe a bit more time, as Sachin was saying, in establishing consent and establishing identity. When you use audio, again, it depends on what form of medicine you practice, but you miss a lot of nonverbal cues, and especially for somebody like me who uses who does ophthalmology, it is very important to be able to see the patient and see the eyes. So it's not really suitable for conditions that require a visual inspection, but I think it's a really useful adjunct to some other forms of medicine. Now, real-time video obviously is the gold standard, but depend on a high-quality internet connection at both ends, which may not always be easy to achieve. So this is just a little slide to show you that you don't need a lot of outlay to set up a telemedicine service. This is a hybrid model. So what we wanted to do was minimize the amount of face-to-face time when a patient came in. So we set up a very simple FaceTime-based system. When the patient comes into an empty consultation rooms, have the initial consultation with the doctor on FaceTime, and the doctor says, okay, I'm going to come in now, I will examine you. So the doctor does that, looks at the patient, and then goes again, and then the rest of the consultation happens again via FaceTime. So it reduces the amount of time you're spending with each other, and therefore the risk of infection as well. So looking at the other barriers, I think financial outlay is something that both the doctor and the patient to some extent are worried about. And again, it depends on the mode of telemedicine you use. It need not be expensive. We have many platforms available, as Dr. Jaideep showed us. And there's a high penetration of mobile phones in the community. So that means we can at least use audio and in some cases video as a cheaper alternative. What Sachin touched on was really important. The other barrier is, will I be able to elicit the clinical signs I need? And I think that is probably one of the most important things. And again, I think it needs a bit of a change in perspective. So what you think is, okay, what data is essential for me to reach a diagnosis and what data is desirable? And if I can't get all the data on the telemedicine, how am I going to get it? How will I get supplemental data acquisition? Can be done by a subsequent face-to-face visit, maybe by using a diagnostic hub or a mobile van, maybe by accessing previous medical records. So it just needs a change in paradigm in how we think about examining the patient. So I've got a little example here. So I'm not a neuro-ophthalmologist like Sachin, but unfortunately I'm a reluctant, I have to become a reluctant neuro-ophthalmologist just because of what I do. I see a lot of patients with strabismus. And here's an adult with a sudden onset double vision of 3 days duration. And of course, they're worried they require immediate consultation. We used a video. And this is what the patient looks like. They have a large convergent squint. Now, this is a problem. And you can think of this as a microvascular problem, in which case you just observe the patient. Or you might have to say to this patient, you need to come in for a scan. And these are quite important decisions to make. So again, you think about what kind of information you need. What's the essential information? The history, how did it start? What are the other symptoms? Are there any underlying medical problems? A lot of the examination, the motility, the pupils, the desaturation, you can probably do a lot of that through telemedicine, which leaves things like vision. Now, you could do some element of vision on telemedicine, but maybe not all. Endoscopy might be really important because you want to look at the optic nerves and the fields. So you'd realize that, again, as Sachin was saying, 60–70% of what you require actually can be achieved through telemedicine. And you might have to find a way to get the remaining 30%. Because a lot of you are not ophthalmologists. I spoke to one of my respiratory colleagues and I asked them what they do to make sure that telemedicine works. So one of the most important things they say is they prep the clinic in advance. They make sure that they know everything about the patient. They have their previous investigations, their previous images to hand. They make sure that its privacy is maintained, so it's an adequate space. They notify the patient of the time and they're seen via Zoom. Again, they obtain consent from the patient. And again, you have to change things. You have to use a history of symptoms to assess the severity of the COPD rather than auscultation or pulmonary function test. But then they said there were some other benefits that showed up. For example, they could get the respiratory physiotherapist to join in. And in a case, they could use MDT quite successfully, which they couldn't before. Okay. And they're actually going to build on this to go on to do pulmonary rehabilitation and patient education using telemedicine. So the genie is truly out of the bottle. We talked a bit about prescribing medicine. That's another barrier. So what can you prescribe and how will the patient access the medication? Now, the Gazette is again, and I think of Jaideep for that. I think that's very, very useful and tells you about the common medicines like in list O, which are available over the counter, and anybody can be prescribed that by video, audio, text, as opposed to the other medicines in list A and B, which need a video consultation before you can do this. Now, how do patients access the medication? Depends where you work. You can WhatsApp them an electronic receipt. In my center, we have linked up with the local pharmacy. So when you finish your consultation, your assistant will make sure that the prescription you have written out or typed out is sent to the local pharmacy. Patient can just go and collect it from there. The other important thing is to protect yourself and to protect your patient. The risk of litigation is a significant deterrent in all countries now. And as Sachin was saying, behave like you would in a normal clinic. Make sure there's privacy. Make sure you do take extensive records, whether it be in electronic form or on paper. Do detail what you could and what could not examine. And make sure there's a clear plan of action that is sent to the patient and their GP. Be aware that although you're not recording the consultations, patients may do. So you just have to have a heightened awareness of what you say and what you do not say. But I think clear documentation is the way forward. This is my last slide, really. The biggest barrier, I think, for me was the fear of change. We've all got comfortable in the way we do things. We have a certain way of examining a patient with a certain condition. And none of us like change, but it's just change has been forced upon us. The things I found useful was to have a complete redesign of the service, think what can and cannot be achieved, and to have a really clear plan of action before you set up. to have detailed record keeping, to recognize the limitations of technology. Not everything you want will be able to be achieved by telemedicine, but most importantly, protect yourself and protect your patients. Thank you very much.
Okay, thank you so much, sir, for clearly highlighting the barriers that one may come across while practicing telemedicine and what are the probable solutions to overcome these barriers. So I think all the three speaker, Dr. Sachin, Dr. Saurabh, and Dr. Jaideep, thank you so much for such a elaborative information and providing various aspects of the telemedicine, including the information on the technology platforms that we can use, that various tools that are available to the medical practitioners, and how to integrate these technologies into clinical practice to provide the healthcare. Now, you'll agree that this telemedicine is at a very nascent stage in India. So there must be some numerous questions from the audience that we have today. So I will quickly move on to the last part of the today's webinar by taking up these questions one by one. So I will start by asking the first question to Dr. Jaideep. So Dr. Jaideep, you will agree that telemedicine is as such is not a new concept. Many people are practicing telemedicine in some or other forms. So the question is telemedicine legal in India now? And what are the probable reasons why telemedicine did not flourish in India as compared to the other?
Right. So you're able to hear me?
Yeah.
Okay, thanks. So right now, telemedicine is very much legal, and it is legal in the sense that there is now regulation. See, till now there have been a lot of good ideas, lot of advisories taken out by the Telemedicine Society of India and some other organizations. But with the MCI coming up with their regulations and the proper regulation which they have said is that there is now a time period of 3 years, and within these 3 years all those who want to practice telemedicine, that is all registered medical practitioners, are allowed to practice the telemedicine right now in India using the principles. But in the next 3 years, they're all required to take up a training course, which the Board of Governors, in precedence of the Medical Council of India, will be conducting very soon. And only those who are certified that by 2023, those doctors who are certified for telemedicine can practice it legally. And they have very clearly specified, you can go to the MCI website and take down the whole thing, what can be done, what cannot be done, what drugs can be given, what drugs cannot be given. So telemedicine has been used. We never called it with this name. For many decades now, doctors have been consulted by telephone. Yes, some of the barriers are, one of the barriers which I feel personally is the barrier that we are all trained as doctors. We are all trained that you must, touch the patient, talk to them, smile, assure them, hold their hand, and all that. Since it cannot be done on telemedicine, that is one reason why people are not very comfortable doing it on a regular basis. Only for emergency or during some kind of a crisis, this has been done. So even now, we are having this big push because of the lockdown, which is related to the COVID-19 situation. So if this was not there, maybe it would still take a few more years for telemedicine to really come up in India.
Yeah, I think Dr. Jaideep has raised a very, very important and crucial point as far as the Medical Council of India is concerned. Everybody has to complete the online webinar or online course for on telemedicine within 3 years of the start. So this is a very, very essential point for all the practitioners. So I move on to the next question. My next question is to Dr. Sachin Kedar. So if sir, I am a beginner, I have not practiced telemedicine before. If I want to set up a telemedicine practice, what are the key essential prerequisites?
I think the single biggest prerequisite is for you to formulate in your mind and get over the barrier that you're afraid of telemedicine. The fear is the biggest barrier. Now, I went over some of the steps that you need to do in your practice. So you have to take a patient encounter and ask yourself, how much of this encounter do I actually need the patient to be sitting in front of me? How much of it can be done remotely? And the second question you have to ask is, can I get all the information that I need just based on this televisit? Or should I have the patient come briefly for 5 minutes to my clinic to complete that? Also, if you're a beginner, start slow, which means assume that you're going to take twice as much time to do that person's televisit as you would normally do. So when I started with twice as much time in that first week. By the second week, I was comfortable enough to where I didn't make a difference between the clinic visit and televisit. So I think fear is the biggest factor over here. But in your mind, if you treat these patients as if you're treating them in your clinic, it becomes obvious. You have to know the limitations. You will once you start doing your telemedicine.
I think this is very, very important. Telemedicine is no different from the in-clinic practice that we do, and all the norms are applicable. So I move on to the next question to Dr. Sachin Kedar, sir. You'll be surprised to know if we go by the results of the webinar poll, more than 80% of the doctors who are attending this webinar, they have used WhatsApp as a tool for using the telemedicine or practicing telemedicine. So the question is, which are the best digital tools to be used while practicing telemedicine?
I think that the government of India has issued guidelines about the tools. Now, these guidelines at this moment are quite lax. So they say you can use any tool you want, but it is your responsibility to maintain the patient's privacy of the data, prevent hacking, and so on. Now, in the US, the CMS, which is a government organization, has clearly identified some of these. The local IT experts in our hospitals have adopted one or two of these tools, such as Zoom, which are what we call as HIPAA protected, or rules which protect the privacy of the patient. Now, in India, the government of India really does not say which ones you can use. Use whatever is comfortable for you. But again, as I said, make sure that, at the very least, that mode of communication is encrypted, that, there's very little chance of it being hacked into. Make sure that you have documentation of it. So, some sort of a log that you call the patient or the patient called you from this time to this time, this was discussed, keep a documentation of it. I have found Zoom to be really good for my tele video visits. There's another app in the US called Doximity. I've used it on occasions. That's also pretty good. Again, idea is for you to be comfortable no matter what tool you choose. If you have to be ready that if your video platform doesn't work, you have a telephone ready to complete that patient encounter.
Yeah, so I think you have pointed out, right, the documentation is very, very essential while practicing telemedicine. So on the similar line, my next question is to Dr. Saurabh Jain. If we talk about the documentation, even patient can record the e-consultation discussion, and that can be used, or I mean, it can be abused. So what are the precautions to be taken while practicing telemedicine, considering the fact that it can be recorded by the patient?
Absolutely, and I think that's something I touched on. When patients record me, I usually say to them, we follow the same principles. So if you're going to record me, I would want to know that you're recording me, just as I'm sure they would want to know if I was to record them. And I think that's a really important principle, something I feel quite strongly about. But as you know, we're not always in control, and especially with electronic media. So what I would say is make sure that you have a heightened awareness of the fact that you can be recorded. Okay, and what I mean by that is maintain privacy of the patient. Behave like as you would in clinic. Be very aware of the advice you're giving, and also be very aware of what you cannot examine and what you cannot comment on. So for example, somebody's asked a question about people giving a false history for want of a medical certificate. And it's very hard, and you can only go by the information you provided. So make it very clear to them what you can and cannot do. and give them a very clear plan of action that here we also send to the GP, so, and document it clearly, and that will protect you and your patient.
So when we talk about the in-person visit, there is always an implied consent by the patient. So when it comes to the telemedicine, is it the same that there is an implied consent by the patient, or we need to take the consent from the patient and do the recording of that consent? So my question is to Dr. Saurabh again.
So again, you have to go by your governmental guidelines. Looking at the Gazette paper, it says that the fact the patient is calling you is implied consent. Here in the UK, we do take consent just verbally, just to say that they're aware that this is a video consultation. We also try and introduce everybody in the room, just so there's complete transparency about who's listening in and who's not listening in. For example, if I have a medical student or an observer, I will always let them know that that's what's happening. And I think that sets the conversation on a good note, and everybody knows where you are.
So the next question to Dr. Saurabh, is this telemedicine is for new patient, or it is also for the old patient who are just doing some kind of a follow visit?
So again, it depends on your practice. I think, of course, for a follow patient, more comfortable because you know the patient, you have the history, you have the result from the past investigation. For a new patient, I can understand people's hesitation, but in this pandemic, for example, we've been running our eye casualty mostly off an app called Attend Anywhere, which is just a video platform. So we have been using this to see new patients. As long as you recognize the limitations and that you won't be able to examine everything you want to, I think you can use it for any kind of patient.
So, over to Dr. Sachin, you must be observing many patients in emergency. So, can we practice telemedicine for the emergency cases also?
Yes, in fact, telemedicine is ideal for emergency practice, non-procedure based emergency practice. Now, you cannot obviously do any kind of procedures over the telephone or over a video. Now, in my institution, we use telemedicine for a lot of conditions such as stroke, epilepsy, multiple sclerosis, and some of these present in emergency rooms. So in fact, telestroke is a critical component of stroke care pretty much all over the US and probably all over UK also.
Okay. So next question is to Dr. Jaideep. So you will agree that this telemedicine practice guidelines have recently come, particularly considering the situation in India, that is COVID-19. So the question is this telemedicine practice a temporary situation, and what is the future of telemedicine in India?
So as I was telling, telemedicine has been in India for a long time. Now, what COVID has done is it has put up all the digital avenues, be it telemedicine or tele-education or even online meetings and conferences like this, right at the forefront. So, and with the movement along with the government's notification, we are, I think, able to carry this momentum forward. And a lot of people will realize that this saves a lot of money is saved, a lot of time is saved, a lot of effort is saved, both for the doctor as well as the patient. And when they realize it, people will definitely take this up as a very good viable alternative. Yes, some technology issues and some logistic issues have to be sorted out, in these coming few weeks, so that people will know that and take it forward. So yes, it is, telemedicine is here to stay. And it's going to really benefit a lot of people.
I will go back to Dr. Sachin. So, Dr. Sachin, you are talking about the emergency cases and the telemedicine. So, can we deny e-consultation, particularly for the emergency cases, or some of the cases wherein you think that yes, in-person visit is more appropriate for the diagnosis and the treatment purpose, and you can stop the discussion in between and you can deny the e-consultation? Is it possible?
So I keep, here is one of the key things about telemedicine. You have to enjoy medicine. You have to enjoy treating the patient. And in telemedicine, my friend Jaideep says Let the doctors do their medicine, let them be doctors, and then there are lots of people who will help you do the other stuff like IT. Now, when you're seeing a e-consultation and you're uncomfortable making any kind of a diagnosis, your number one rule is this an emergency that the patient needs to go to the casualty? If that is the case, you provide first aid, terminate that e-consultation, and make sure that they go to the emergency or casualty. In all other cases where it is not a life-threatening problem, you can terminate the e-consultation anytime you want after telling the patient, hey, I don't think this is possible. I want you to come here and see me, or I want you to go to the hospital. It is perfectly okay. But then you have to document it, tell the patient that, and make sure that everything is recorded for you.
There is a next question from Dr. S.K. Bagra, who is asking telemedicine versus personal visit consultation. What are the probable chances of misdiagnosis or underdiagnosis illness by a doctor? And will this come under Consumer Protection Act and punishable under law? Dr. Saurabh.
That's a very good question. And again, it depends on what kind of medicine you practice and what you do. So, as I said in my talk, some things you can assess and some things you cannot assess. And I think it's really important that you are very clear to the patient about what you can and cannot do. So going back to the example I had about a patient with a sudden onset sixth nerve palsy and double vision, you have to tell the patient, listen, I have looked at you. I think this is the diagnosis. However, I cannot assess this, this, and this, and I need to know this to be able to say whether you need a scan or you don't need a scan. And I think that's absolutely fair enough. So it depends on what you do and what kind of, again, you follow the same principle you do in clinic. You can only go up to your comfort level and not outside that.
Coming to the next question, which is very, very interesting for Dr. Jaideep. Do we need to write any disclaimer on the e-prescription that this is the decision based on the telemedicine and it may require some in-clinic visit as well? So any kind of a disclaimer that is required.
Right. So we have to sort it out as doctors first, because once again, to quote the guidelines, they're very clear that you have to take this as part of your normal consultation only, and you have to reach your decision. Whatever be the tools you need, reach your decision, and if you are not able to reach your decision, a clinical decision, by just a teleconsultation or by getting data from various apps or instruments, you must insist that the patient has to appear in person to the hospital, either his own hospital or clinic, or to some other place where an in-person consultation is required, where a procedural emergency has to be conducted. And in fact, the consultation can be terminated at that point to avoid any complication. And when, if all that is not there, you're very sure of the diagnosis and you're sure that the judgment, that your clinical judgment that you're making is absolutely correct, you can issue a prescription, and that prescription is as good as any other prescription. So there is really no need for a separate disclaimer, though by appearance itself it will be an e-prescription which will be different, and that should suffice. But I think in the coming days, as people start using it, we will, the bugs will come out, and we'll be able to see what steps have to be taken.
Dr. Sachin, it is said that we doctors should be available 24/7, 365 days. So still, can we deny any e-consultation, specifically if you are busy or it is out of your consulting hours?
As far as I know, you are not obligated to take any consultations that is outside of your work hours, outside of your area of expertise, outside of your comfort level. I don't think there is any compulsion for you to take e-consults.
Okay. Dr. Saurabh, next question is for you. Can we use WhatsApp chat as a mode of telemedicine? And does it qualify as a telemedicine practice? And can we charge for that particular service if the discussion is happening basically on the WhatsApp chat?
So this is very difficult. Again, you have to be guided where you practice. So in the UK, you're not allowed to really use WhatsApp for any medical consultation. You have to use something called Pando, which is approved by the GMC. Now, going by the Gazette article, they do allow you to use WhatsApp, and I think the problem with charging is it has to be done before the consultation begins, or the patient has to be made aware of it. Charging people retrospectively is very, very difficult. And it's a very fine line because it might be just a couple of questions about a prescription and you might think, fine. But then if it's a full-on consultation and they're sending you reports and if that's something you charge for, I think you should make it very clear to the patient that's what you want to do. But yes, I think it can be a very effective mode of treatment. And I see a lot of patients from overseas who communicate with me via WhatsApp.
Okay. So on the similar line, I would like to ask Dr. Jaideep, as laid down by Medical Council of India, can we charge the patient for telemedicine services? And is there any cap as far as the charges are concerned? Because one may think that it is a digital kind of a consultation, so you may charge something less as far as the patients are concerned, and doctor may say that I may charge somewhat higher than what I usually practice.
To quote the exact words, the MCI says, please charge the same charges as you do in your regular clinic. So there's absolutely no difference. It is not a charity that you're doing just because you're not seeing person to person. If you're charging in person, please do charge for the e-consultation as well.
So moving on to the next question for Dr. Sachin, is telemedicine applicable for prescribing injection as well? And what are the medications that we cannot give by telemedicine?
It again, it depends upon your practice. Now, I would avoid giving any high risk medications. You have to first look at the guidelines by the MCI. There is a very clear list of medications. The easiest ones to do are over the counter medications. Now, by injections, if you mean things like insulin, now if it's a follow-up patient, somebody that you've seen before, you prescribed them diabetes medications and now you want to adjust their medications, fine, go ahead. But if you're going to prescribe them a new medication, then you've got to be careful. In those cases, what I would say is, again, back to clinical judgment. Think about, is there a difference between this patient coming to see me in clinic versus seeing me in telemedicine? And can I make the same decisions, or is there anything different? That's how I would put it. If you're not entirely comfortable that you have not examined X, Y, and Z to make your decision, then don't do it. Have the patient come in, finish that brief visit as a hybrid model, and then you can prescribe it. So depends on what your practice is and what injection you're talking about. If it is a follow-up patient, I would say go ahead, you can make those changes, let the patient know. If it is a brand new prescription of insulin or maybe a narcotic or something like that, then I would say be careful.
So moving on to the next question for Dr. Sachin, there is one interesting question and a very, very common question that everybody will have at this point in time, which is the best app for telemedicine?
The best app for telemedicine is the one that you are most comfortable with, is my answer. So in the US, we have very strict regulations. It has to be a HIPAA protected encrypted software. Since I work at the university has prescribed one or two tools that I can use. The ones that we use commonly is Zoom, because it is integrated into our electronic medical record. Now, you will be guided by the Government of India Gazette. And in the Government of India Gazette, they give a whole host of tools. If you're very comfortable with WhatsApp, go ahead and use it. If you're comfortable with Zoom, go ahead and use it. Messenger, go ahead and use it. The idea is not which tool is the best. The idea is which tool are you comfortable with and which is the tool that your patients are using the most, so that you don't have to struggle with them coming online. So you have a leeway given by the government of India at this time. Go ahead and use it. Use what you have. You are a doctor and you should practice medicine. Don't try to do IT. Let the IT people manage IT.
So thank you, Dr. Vijay Kerde. I am sure that you must have got your answer. So on the similar line, there is another question from Dr. Bala Chandar BB for Dr. Jaideep. Zoom versus telemedicine software comparison. What is the present status?
Zoom versus?
Telemedicine software. There are numerous softwares are available.
Yes. New softwares. See what happens when we are using other softwares. See, unlike right now, like what Sachin was telling about UNMC incorporating Zoom into their existing system. Right now, we are using Zoom like this, as a one-off. It's just another video call thing. But if you are using specific softwares which you are able to link with your electronic health records, which you're able to link with your radiology or your pathologist, or even, for example, your pharmacist, then those apps or those softwares will be much better. But again, to re-emphasize the same message from both Sachin and myself is that, see, there are things in which doctors are good. Let's stay at that. There are things which techies are good. Let them do that. Because the moment we try to do all these things together, uh, there's a lot of delay. The uptake is less unless you're an expert. Yes, if you're an expert, please do go ahead, suggest, tell us, share us. So yes, telemedicine specific softwares will be always better than using one-off communication software. Zoom is a communication software, and telemedicine softwares will be other things.
Okay. So the next question is to Dr. Saurabh from Dr. Govinda Rajan. What is the chance of hacking of data by a third party, especially in this era of cybercrime?
That is a very good question, and something we are very aware of after GDPR. So in the UK, if you keep any data at all with you, you have to register with the Information Commissioner's Office. So what I would say is have a secure way of saving your data. So you can either do it using paper notes. You have to have a secure lockable. If you're using an electronic patient record, have something that has been certified as secure, ideally cloud-based. So I don't any patient data on me whatsoever. And I think that's very important that you follow local guidelines wherever you are.
Okay. So moving on to the next question for Dr. Sachin, what should be an ideal duration of telemedicine consultation so that it can qualify for the telemedicine consultation and doctor can charge for that? So what is the maximum or the minimum duration?
As I said before, do not make any differentiation between your televideo visit and clinic visit, except in that first 1 to 2 weeks. So in the first 1 to 2 weeks, I would say make it double the clinic time that you have. So you want to understand what the problems are, what the kinks are, and then get rid of them. Now I don't make any difference. As a neurologist, I have a 1 hour slot for a new patient and a 30-minute slot for a follow-up patient, both in my clinic and in my televideo visits. I don't make any difference between the two. The reimbursement in the US is guided by what we call as CMS regulations and insurance company regulations. We have no say over it. They have very specific criteria and we just try to follow them. In India, if I understand correctly, any practitioner can decide what they want to charge the patient. When you do that, make sure you clearly inform the patient that I do not make any difference between when I see a patient in clinic versus televideo visit. As Jaideep had said in his talk, you're not doing charity. This is not suboptimal, or this is not a cheaper variety of your clinic visit, because if you do that, then you'll only be inviting trouble for yourself. I tell my patients there is no difference. If I need to see you in clinic, I will see you in clinic, but I think this visit is good enough.
I think we are towards the end of this webinar, so I will take very quickly last few questions which are very, very important. So the next question is for Dr. Jaideep. there can be chances of some technological errors because of the poor connectivity, because of the poor network. So that may result into the misdiagnosis or misunderstanding by the patient. So what are the legal implications of this?
So even if there is a bad network, you don't go ahead and conclude your consultation if there is any doubt regarding the network. So we like how Sachin was saying, wait till you know the answer, wait till you are able to make the correct diagnosis, and make sure that there is no doubt both in the mind of the doctor as well as in the patient. So yes, technological issues are there, but I think we have to take time to make sure that we are not making any mistakes. So if we are making sure of that, then there will not be any complication.
Okay. So my next question is to Dr. Saurabh. This question is from Dr. Jayesh Balsara. He is asking, can we issue medical certificate following the teleconsultation?
So that's a very good question. Looking at the guidance, I think we can, but you have to have the confidence in the information you have been provided, and you can only go on what you're told. So again, it varies in different countries. In the UK, you can absolutely issue a certificate even on the phone, even in normal times for up to 2 weeks. So yes, I would be happy to do that. Yes.
Okay, there is another interesting question in continuation to this by Dr. Vijayanti Mala. Dr. Vijayanti Mala is asking, some patients may give you a false history just for seeking the medical certificate for leave or some other purpose. So how to manage such case?
I think it's the same as you would in normal clinical practice. You have to be confident of all the information you are being given, and you can only go on what you're told. And that is a problem, even in normal clinical practice. Somebody says they cannot work because of X, Y, Z, and so somebody says they can't walk, and there's only so much you can do. You have to take the patient's word for it.
Yeah, moving on to the next question, probably last couple of questions for Dr. Sachin. What is the importance of documenting as far as the telemedicine is concerned, and what should be the ideal way of documentation?
So again, in my practice, my documentation is exactly the same as in a full clinic visit. I use the same pattern and add one paragraph to it saying this visit was conducted using telemedicine through a video platform for X amount of time. Patient, his relative, doctor, and my assistant were present for this visit. So I add a paragraph saying this is a tele video visit or this is a telephone visit for X amount of time, and these are the participants. Rest of the documentation is exactly the same. The same components of your history go in, the same components of your observed examination goes in, and then you say, yes, the examination was limited because it was a remote connection. But again, I would emphasize again and again repeatedly that do not make any differentiation between your clinic visit and televideo visit. Yes, you document that this is a televideo visit. Yes, you tell your patient that this is a televideo visit, but your medical judgment should be no different on televisit than on a real clinic visit.
So moving on to the last question of the day from Dr. Nitin. If there is any emergency and we don't have any time to take the consent, so what should we do under such situation?
Who is this question for?
Yeah, Dr. Sachin.
An emergency is an emergency. If the patient cannot give you consent, it is your responsibility to give them first aid emergency treatment to the best you can, which means either you treat the patient or you send the patient to the casualty or emergency room if they can go there. But it is our responsibility. We have to treat the emergencies the best we can, and it would be the same as seeing an emergency when you're maybe traveling. You would provide the care that you can to the best of your ability. That's pretty much all I can say. Consent in those situations is actually implied even in the US.
Okay, thank you. I think the questions are still flowing from the audience, so, but in the best interest of the time, we will stop over here and probably we will try to address the remaining questions offline. So with this, on behalf of Wockhardt Medical Connect, I thank Dr. Jaideep, Dr. Sachin, and Dr. Saurabh for their insightful sessions and effectively addressing all the queries from the delegates and sharing their experience in this field. So thank you so much for your valuable time and sharing your experiences. At the same time, I thank all the delegates who have joined us from various parts of the world and has shown their interest in the topic and the discussion. So thank you so much and good day to all. Thank you.
Thank you, everybody.
Thank you so much.